when would I consider a conservative management of insertional Achilles tendinosis? And if it's failed, and what should I do for the patient? So we have this patient, 24 years old, a short distance sprinter in national level, complained of posterior heel pain for 1 year with decreased performance, and they try all the non-operative treatment. And what should we do on this X-ray with the patient complaint? So posterior heel pain, one of the common cause is insertional Achilles tendinosis. Achilles tendon is the largest and strongest tendon in human body and insert over the posterior superior aspect of the calcaneal tuberosity. And it exerts enormous continuous functional demand during gait. And because of the poor blood supply, is susceptible to various types of acute and chronic injury. And this condition are very common in the patient with a lot of running, jumping, because there's a direct correlation between the injury and the intensity level of the training program. And slowly this will become a micro tear in the tendon and eventually progress to a macroscopic tear. Because of the various factors, there'll be an extrinsic factor, like they train in a poor surface, with the poor shoe wear, with the training error and overuse. There may be some intrinsic factor also, like a tight gastrocnemius muscle, malalignment of the lower limb. And because of this, they have a repetitive trauma where it causes microscopic injury, inadequate healing, and lead to further injury. So the insertional Achilles tendinitis is occur within and around the tendon at the insertion, but some condition like bony prominence, like heart lung deformity, may resemble this type of symptom. So patients usually come to us with posterior heel pain, and there may be a posterior lateral prominence on the posterior calcaneum. There will be pain increased during walking or running, and of course, they are also pain when they're wearing a tight constrictive footwear. And shoe with a closely counter heel counter in ladies also usually can cause this problem. And examination, there may be some swelling over the posterior heel. There will be a decreased range of movement and tendon thickening. The location of tenderness is very important. Sometimes they may be in front of the Achilles tendon where there will be a retrocalcaneum bursitis, and most of the time they will be at the insertion of the Achilles tendon. So you need to check the tightness of the gastrocnemius muscle by doing the silver squat test also, whether this will be a factors. Then subsequently, you need to do a plain X-ray, where a standing plain X-ray, then there will be a 6 possibility. In the A picture, there will be just a purely Achilles problem because they don't have any spur. In the picture B, there'll be a big heart lung deformity rather than the purely Achilles tendon problem. And in the picture C, there will be a big spur around the insertion of the Achilles tendon. And picture D, there'll be a calcification on inside the Achilles tendon. And in the picture E, there'll be a big spur there. And also there's some calcification over inside the Achilles tendon. And the worst one is they have a big calcification as well as the spur over the tendon. Occasionally, you can do a ultrasound to see any calcification inside the Achilles tendon. MRI sometimes may be helpful to help us to see whether there is some retrocalcaneum bursitis rather than inflammation at the tendon itself. So the treatment can be a non-operative, a short duration of NSAID and rest. There may be decreased activity modification, and some shoe modification. Stretching is very important in the calf stretching, and you can ask the patient to pull using the towel or stand at a staircase. But this is my favorite board where you can have a very nice calf stretching for this patient. I usually ask them to stand on it 25 degrees of inclination with 5 to 10 minutes, 2 times a day. And 90% of the patient will respond to this kind of home stretching exercise. If the patient have malalignment like overpronation, then you can use the medial arc support to correct when the patient is walking. How about corticosteroid injection over this area is really discouraged because it's really increased the risk of the tendon rupture. So depending on the X-ray finding and also the symptom of the patient, when you see there is no big spur over the X-ray and the Achilles tendon, sometimes I will use rich plasma, the PRP injection, and over the tendon because the success rate to decrease the pain and healing is about 90%. However, when there's a calcification or there's a big spur, the success rate of PRP will be only about 30%. So in this patient, 24 years old short distance runner with national level, we try non-operative and feel what can be offered to this patient. This is a prominent of the procedure area. So in the field non-operative management, then I will offer the patient calcaneoplasty, where we use a midnight incision to expose the tendon and then detach the Achilles tendon from the insertion, took out the major part of the bone spur that in the left pictures, and also a big part of the bone. Then you use the second video is to smoothen out the edge on the side and also the posteriorly, and then you use the anchor suture to anchor back the tendon. And then at the edge of the tendon, you can use the wicre to suture it back into the position. So this is a calcaneoplasty. This the amount of the bone that we remove in this patient. So in the 4 months of rehabilitation, and the patient slowly go back to his running capacity, but it took about 9 months, only can go back to the previous performance. Post-operative rehabilitation, give patient 2 weeks of front slap for the wound to heal. And then at the second week, we give the patient a weight-bearing boot with 3 wedges. We've removed 1 wedge every week for 2 to 6 weeks. And then in 8 weeks, they off the boot and also with the aggressive physiotherapies. So in summary, insertional Achilles tendinosis is very common in my practice. A good home gastrocnemius stretching exercise with a stretching board is very helpful when 90% of patient is respond to this, and a short duration of the NSAID. And if there's no bone spur over the Achilles tendon problem, I will give them a PRP. And if they feel the non-operative treatment, then I will offer patient a calcaneoplasty with an acceptable functional result. With this, I thank you for your attention.